Hello, everybody. We are now streaming on Facebook. If the guests can mute themselves, if everybody can mute themselves, that would be great in the room. So Teresa's entering. There's just a few more people. They're gonna keep rolling in over time. So hey, Teresa. I'm gonna get started pretty promptly, and then as people roll in, I'll just admit them into the room. But thank you for coming tonight. So what a day, huh? It's only Monday. Oh no, it's Tuesday. Okay, Shelly's coming in.
No, it's Monday.
Oh yeah. Is it Monday? Yeah.
Yeah, it's Monday.
Right. It's like, I can't tell. Hi, Shelly. Shelly's one of my clients. Okay, so as people roll in, I'm just gonna let them in. So welcome everybody, and welcome everybody in my Goodness Multiplied Facebook group pages. And tonight I'm really excited because we are on day 2 of a 3-day live health expert talk on chronic pain. And tonight we have a special guest expert, Dr. Jason Fond from Northeast Orthopedic and in Nyack. And I will be introducing him in just a minute. But before I do, just welcome everybody as you settle in. We're gonna be on this for about a half an hour and end with 15 minutes of Q&A. So half an hour of discussion and questions. And if you have questions, either put it into the chat or the comments. If you're on the Facebook pages, just chat your comments into the Facebook comment section. Or if you're in the Zoom room, put it into the chat box. So welcome everybody. Time is now. So let me ask you guys something. What does your best life look like? And where will you be 20 years from now? What we do right now sets the tone, is a garden that you're basically cultivating for the next 20 years of your life. And if you're in your 50s and 60s and in your midlife, this is an amazing opportunity to look at where you are really right now, acknowledge where you are. And if you're struggling with chronic pain on a daily basis, let me ask you this. If you're having difficulty walking, if you're having difficulty with mobility, let me ask you this. Where is your quality of life right now? And so tonight's discussion is really going to be focused on prevention. It's going to be talking about some things that you can do to really take your power back. So take your power back with your health. And what you do right now can set, 2 different paths. You could be 85, 90 years old doing ballroom dancing, which I would like to be doing, or you could be in a wheelchair or walker. And not to scare you, but those are 2 paths. You know those people who are in their 90s. And so today I want to encourage you that it's totally possible. It's completely possible, even in your 50s and 60s, to turn things around, to get control over your weight, decrease inflammation, and live a life of vitality, and really cultivate a body and a mind and a heart and, physicality and a life that you really dream of. So, without further ado, I want to introduce my guest speaker, or my guest expert tonight, Dr. Jason Fond. Thank you so much, Dr. Jason, for joining us.
Sure. Hi, Tina.
Hi, yeah. So he took time out of his extremely busy schedule to be with us tonight. So I'm so grateful. Dr. Fond is a dual board certified orthopedic surgeon and sports medicine specialist. He is one of the partners and owners at Northeast Orthopedics and Sports Medicine in Nyack, New York, and with several locations. And in addition to his position at Northeast Orthopedics, he is also the director of orthopedic surgery at Nyack Hospital. And I could go on, but I want to highlight some of the things. I met Dr. Fond at a networking event, and what I really loved about him was just his very approachable demeanor. And for many doctors, that's really hard to find, right? So you really want to have someone you trust and you can talk to and feel safe with. And that's one of the things I loved about when I met him. And so he is America's most honored professionals back in 2017, top 1%, Castle Connolly's regional top doctor in 2017, New York metro area's top doctor, Castle Connolly doctor multiple years in a row, and the most compassionate doctor according to Vital Patient's Choice. So I'm just so impressed with all the awards you've received over the years. And he graduated with his medical degree from the Albert Einstein College of Medicine and with honors from Tufts University. I think we had that Boston discussion, right?
Yes, yes, we did. Yes, we
Way
did.
back, yeah. So Dr. Fond is in New York in his office, and in Westport, Massachusetts, and our audience is across the country. We have people from California joining us. We have people from around the world possibly joining us on the Facebook page. So welcome everyone, and I want to just begin with some questions for Dr. Fond, if you don't mind. Can we?
Sure.
Yeah.
Absolutely. Anything you want.
Do you want to say anything, or you want to just jump in?
Yeah, sure. So I just wanted to and thank you for those very kind words. And I would like to say that what Tina does and what she has sort of educated me about with respect to what I'm sure people who know her has taught you or has helped you with is very important, even in my profession, extremely important. And people have views of surgeons as people who just want to operate or just want to, whether it's financially driven or whether it is, just a sort of very direct and practical approach. That's not necessarily true. And the reason that I went into this as a career was to help people. That's the bottom line. Now, whether I help people non-surgically, which is what many people don't believe, but probably about 90 to 95% of my patients I do not operate on. So most patients, particularly with respect to musculoskeletal issues, are treated successfully without surgery. So just for if there's a fear of, people are scared to go to the doctor, particularly surgeons, it's important to remember that. And I think that if you're made to feel otherwise when you go to see a doctor, find a new doctor. And that's, I think, probably the most important thing I can tell you. I tell patients all the time is that if you're not happy with your physician, you don't like what they hear, there are a lot of us out there, and you will find someone who understands your point of view, understands your disease process, and understands the things that you're trying to get out of your life. Everybody's different. So one diagnosis doesn't mean one treatment. There's many different ways to look at things, and I think that's important. And you patients have power, and I think that patients have to understand that with communication with their physicians, that they can sort of, get to a solution that benefits the patient. That's the most important thing.
I love that. I love that. I knew there was a reason why I had to have you on, and I'm so happy that you agreed.
Tina, you're putting so much pressure on me that I need to be perfect.
No, but it's truly, I felt instantly comfortable with Dr. Fond when I met him, because his demeanor is very approachable, like I said, and it's so hard to find, especially with surgeons who have very busy schedules. And he's absolutely right. And I know from personal experience in spending a lot of time in cancer hospitals after being, being a part of my dad's 10-year stage 4 cancer journey. I was in Sloan Kettering Hospital over a period of duration of 10 years, in and out. I was there so much they thought I was part of the hospital staff, honestly. And I know for certain that people don't necessarily even know how to ask the questions. Sometimes they don't even know what questions to ask. They go in and basically have been given some options or given a direction, and then basically they just go from there. So it's not like they ever really raise the questions in terms of what they need and what it means for them and what the implications are in terms of their home life, in terms of their support around them. And I love that about you, Dr. Fon, that you are really considerate about the whole holistic aspect of a patient's life.
I think that it's very important that, people are listening, when you go to a physician, no matter what it's for, that you should not leave the office without understanding your problem. And I know that seems obvious, but if I had $1 for every time a patient came to me from another physician and didn't understand why they were even in the office or what was wrong with them, I mean, it's very surprising to me. And, I have to attribute my parents, because my mom was a nurse, and I think that she beat it in my head for a very long time to, to first of all treat nurses very well, but also to, just the way you speak to patients. And my father is a patient for a long time, so I heard that aspect of it for many years growing up. So I sort of have that take on it, and I think that it's. I try to every session, every patient appointment I have ends with, please tell me you have no questions. Do not leave here without any questions. And particularly when it's a surgical issue, it's very important that they understand the whole process. So it's very important. Right.
I love that. So tonight we're really talking about pre-existing chronic conditions that people might have been living with for a long time. And so can you give us an idea to what, at what point in their chronic pain journey, whether it be an injury or lung or osteopenia or, excessive, wear and tear on their joints? I mean, basically, at what point do they come to you?
So it varies. I mean, people have, and that's the other thing that's very important. And for all people listening, that a diagnosis isn't the same for patient A, patient B, patient C. You could have the same diagnosis as two of your friends, but your perception of your pain and your disability and your difficulties with your life are different, because you need different things, right? You act differently, your body's different. So it's very important everyone's an individual. So I treat everyone individually, and I could see, today I saw a lot of people today, and I probably saw, if we're talking about our, wear and tear or arthritis or joint breakdown. I mean, I saw 30 people today with that diagnosis in some shape or form. And my job is not to tell them what to do. My job is to educate them as to their diagnosis, to give them options, and to guide them. And that's my job. And I think that that treatment plan is going to take different courses depending on their underlying issues, their age, their activity level, comorbidities. And I think that, physicians, whether you're an orthopedic surgeon or you're not, you need to take that into account, and you treat people differently. And I think that we need to take those comorbidities particularly into account, because if I have a patient who, for example, has knee arthritis and is a marathon runner, I'm going to treat them differently than a sedentary person who's obese. And I think it's very important. You're going to have different conversations with those patients because their treatment plan is strikingly different.
That's so true. So tell us, like, what are some of the most important determining factors in terms of a patient to move forward with a decision for a joint replacement? And can you just tell the audience what joints you
right? So to back up a little bit, why does someone need a joint replacement? So first of all, no one needs anything. So I always tell patients, I'm never going to tell you need anything. Every patient who I replace their joints, and I replace shoulders, hips, and knees, but I have replaced elbows as well for different reasons. But The reason is that there's joint destruction.
Mhm.
So why the joint destruction typically comes from cartilage or joint surface breakdown from wear and tear, genetics, or something rheumatologic, rheumatoid arthritis, psoriatic arthritis, something like that. So that's why patients come to me and who are referred either by their friends, their family, something, their doctors, whatever it may be. And I will say that I do not operate on patients. I will never operate on someone the first time they walk in or the first time they've sought treatment, because that's not necessary. Usually patients can respond to conservative treatment, and conservative treatment involves physical therapy, medication, whether it's over-the-counter prescription or supplements. Lifestyle changes. Okay. So as we know, our population has become more heavy or obese over a long decades. And that's, an epidemic in this country. And then there's interventions, there's injections and things like that. So for the audience, I'm a speaker for a company, for Johnson & Johnson, actually. It's a large company, but they do, one of their products is what's something called early intervention, which is at the outset of arthritis for patients. And one of their products is something called hyaluronic acid, which many people may know about, but it's something you can take orally. But it's something that I give injections for, and you can inject that into the joints. People can even inject it for wrinkles and for cosmetic reasons, but I don't do that. I inject it for inflammatory reasons and things like that. And so I speak about that, and it's very important that that's part of the whole process of conservative or prior to surgery, the treatment plan prior to surgery.
So let me ask you this. How often do you have to turn away patients because of obesity?
So to talk about obesity, there's a slide from these talks I give, and I wish I should have given it to you. There's a slide that shows over the last decades how in our country, and it goes state by state, and how you can probably look it up, but how the percentage of obesity in our country has increased exponentially. And so I see patients who are, overweight / obese, because obesity, that diagnosis or that definition is not hard to hit, right? So the BMI or body mass index that patients have, it's quite high. I mean, technically, I'm way overweight if you read this, and I'm not, but I'm way overweight by this chart. But obesity or when you have increased adipose tissue or fat cells, it creates a couple things. Number one, it's mechanical, because because the increased load causes the joints to break down. And the increased fat cells will cause more inflammation and problems that way. I'm getting a very roundabout way to answer your question, but
that's okay.
The patients who have obesity, I have a long conversation with them, and I explain to them that, look, your obesity is going to cause increased complication rates after surgery. So I try to develop a plan with them, nutrition-based, exercise-based, consultant-based, with someone like you, who basically we can sort of develop a plan to try to, counteract that obesity as much as possible. And that's very difficult because it's hard to exercise when your knees hurt, so it's very difficult, but it's a plan that patients have to go on. And I will not operate on someone, you want to talk about lines. So if you have a body mass index of over 30 and a weight of over 250 or general sort of lines, but that's different because it depends on your height, it depends on your musculature, it depends on a lot of different things.
Yeah, that's exactly why, sorry to interrupt, but that's exactly why BMI is not a good indicator.
No, it's
so
not.
BMI have been developed by the World Health Organization, but is height over weight. And everybody's different shapes.
It's a very, that's what I'm saying. My BMI, if you looked at my BMI, I'm obese. I'm 5'10" tall. I want to weigh 180 something pounds, and I'm in pretty decent shape, but I'm not obese. So that's why it's a very sort of, slanted, and it's archaic. It's been around for a long time.
Right.
So I'll give you one example. I don't know if I told you this. I saw a patient in my office literally last Thursday.
Mm-hmm.
She came to me, she moved from another area. She's 47 years old and she's limping and she's overweight. She weighs about 270 pounds and she's about 5'6".
Mm-hmm.
And she has she has bad knee arthritis on x-ray.
Mm-hmm.
So I started the conversation and talked to her about the weight loss and dietary issues and things like that. And she chuckled and I said, "What's so funny?" And she said, 6 years ago, she weighed 986 pounds.
Oh yeah.
So, I sort of was taken aback. And so she lost 400 pounds on her own. And then she did the rest with surgery. And I'm not going to, she's booked for surgery. She's someone who she lost,
Mm-hmm.
she lost 700 pounds. I'm
Mm-hmm.
not going to tell her to lose 50 more. So I think that there's every decision, everything's a little bit different. I see patients who, patients I send for nutritional consultations and physical therapy frequently right off the bat. And I think that number one, they may avoid surgery altogether because if they can sort of change their lifestyle, change their way that like I said, nutrition, whether it has to do with supplements or food or their activities and their lifestyle, they may be able to avoid this completely from the start. But so that's certainly something we try. And I have patients who are struggling with that because they're very unwilling to change their lifestyle. But I turn patients away every day.
Wow. Wow. And so you do see significant percentage of patients coming in with obesity. Now, is obesity having a certain body weight, like say 100 pounds or over 100 pounds overweight, over, BMI or over, norms, could that actually initiate joint problems?
Yeah. So as I said, so I think that, right. So when you're
Mhm.
of increased weight,
Yeah.
you're going to cause stress on your joints, and that can lead to increased and sort of accelerated joint breakdown. The cartilage can break down.
Mhm.
Um, you can,
Does that happen over time
yeah,
or like
typically over time.
over a long period of time or?
It varies. I mean, long is subjective. I think it can happen.
Mhm.
It can happen quickly
Yeah.
over a short period of years, not necessarily decades.
Mhm.
Um, and I think it leads to inc- um, poor muscle tone, poor function, muscle fitness,
Mhm.
and as I said before, increased inflammation, which leads to increased pain. And I will say that if you have this sort of circle, so it's like a cycle, right? So you get stuck and it just sort of happens, and you want to try to break that cycle. I won't operate on people who haven't tried or who haven't gone through the process because the complication rate for these patients is much, much higher.
Does it double?
Depends, but it can be very high. So double is probably accurate. I think that risks of wound complications, stiffness, instability, meaning, when we put an artificial joint in, you're cutting bone and muscle and ligaments. And if you go in with a patient who has poor muscle tone, poor nutrition, that which decreases their ability to heal, they have wound problems, they have infection rates are higher, they have stiffness, decreased patient satisfaction, and then
Mhm.
failure of the prosthesis.
Mhm.
So the prosthesis, I don't care how strong, no matter how strong a metal may be or plastic may be, there's a certain amount of force that will disrupt that. And when we put these implants in, the bone that they're in may not be the strongest bone. And if the more weight that's being stressed on that can cause that implant to fail.
Right.
And if you have failure of that prosthesis or infection or wound problems, that's a disaster. I mean, you're talking about another surgery or multiple surgeries, limb threatening in some cases. So it's something that, as surgeons, we don't want that. I tell patients all the time, I don't want to operate on you once. I certainly don't want to operate on you twice. So
Right.
I think that, that's very important.
I
Yeah.
think I've heard that too. Yeah. It's amazing what the cost of poor health can be over the long term. And you think it's just about, well, I have a few extra pounds or maybe I'm 50 pounds overweight or whatever. But people it accumulates, and before you know, if there's not consciousness about it, there's not awareness about it, or they're afraid, or they're not feeling good about themselves to begin with in their lives, whatever they're dealing with at home, and especially now in the midst of COVID. There's a lot of people who are sitting in their homes alone, unable to move, and feeling completely unsupported. And
Yeah, it's
yeah.
very difficult, and I think that it's hard. You have to toe that line with patients. I'll mention weight loss to patients, and I'll get multiple reactions. Some people get offended and walk out. Some people embrace it and say they're trying, and other people are sort of, it's like I never told them. No one's ever told them they're heavy. So I think that I have to sort of manage that, and I think that sometimes it's important that patients need to hear it. It's obviously the way that you say it and how your presentation is, but
Mhm.
I think it's I think patients need to understand that they have, like I said before, they have power, and I think they have power in their own health. They have power to change this on their own. They can't, although they have people like you and I to help them.
Mm.
This is, they need to have the strength to do some of this themselves, and I think that us sort of emboldening them and sort of getting them to understand that, I think is very important.
Yeah. So briefly, like in the midst of this COVID situation, what's the surgical situation going on right now? Are you seeing more comorbidities coming in? You have to take extra. What's behind the scenes? In
So,
your
it's the thing I'm seeing more. You see sort of these vast fluctuations. Patients will be sitting around doing nothing, and then our active they'll sort of go out and they'll start to exercise like crazy, and then they come in with these flare-ups of pain and muscle because they're not at a steady state, right? So whether it's emotional, psychological, physical, whatever it may be,
Mhm.
our lives have been disrupted. So we are not doing the things that we normally do. People who work and go to work every day, you're walking to work, you're walking at work, you're doing your daily thing without even exercise. And now
Right.
these people are sitting at home in front of a computer all day. So I see so much of that, and people are stuck.
Mm.
And it's easy for me to say, go out for a walk, go do this, go do that. But I say, look, you're here. I see that it's every day. But when you're sitting at home, you need to be conscious of it. Get up and move, 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 right?
Mm.
You need to get out there and sort of understand that your life has changed and you
Mhm.
need to adapt with that. And
Yeah.
people in my age group and people in your, early 50s who were not the same as we were in our 30s. So you can't get away with that anymore. And I
Right.
think that it's important to understand that your fitness isn't just going to happen. You have to be active in that.
Mhm. Yeah, that is so true. And basically, if we don't take care of, I mean, even just a little bit can accumulate and add up in terms of what we do or what we don't do. So what we seed and garden in our bodies and our activities actually are really gardening or cultivating our garden for the next 20 years of our life or the next 10 years of our life. And so a couple more questions. In terms of age related sarcopenia, or bone loss and muscle loss, sarcopenia and osteopenia, like, and complications with obesity. Like, I mean, I guess my question is, like, there must be extra care that has to be considered when you're looking at surgery, obviously, with joint replacement.
Right. So I have to be, so, with respect to pre-op, I really, as I said, we go through the whole, you need to lose weight, you need to do this, you need to do that. And I educate with respect to, sometimes you have to bite the bullet, so to speak, and go forward and have the operation.
Mm-hmm.
And the surgeon needs to make sure that they've accounted for that with respect to their technique in surgery, with respect to the implant that they use. So I use different implants for my obese patients.
Oh.
Um, yeah, they're more supportive
Mm.
because the bone will fail. I mean, or be, structurally not as sound. So I'll use different implants. Um, Look, the surgery's harder.
Mm.
I love my job, but I'd rather it go easier like everyone else. So the surgery's harder. and takes longer. And the longer your surgery takes, the more complications you have with respect to infection and other things like that.
Mhm.
So I'm motivated
Mhm.
to educate my patients to lose weight and to, whether it's weight loss itself or get stronger.
Mhm.
Prehab is very important, like rehabilitation preoperatively is very important.
Mhm.
Um, I just want my patients to do well.
Yeah. Is
Uh,
there a correlation between obesity in terms of health, overall health of the patient, and the um, stability of their bones? So if they are obese and of in their 50s and 60s, and they haven't been taking care of themselves for a long time, does it show up in their bones? I mean, I
yeah,
know
I mean,
that's like a
so
silly question, but you're in there, so tell us.
yeah, it's very interesting. I tell patients all the time, and not to get too graphic, but I sort of, you have bone density tests that we recommend in patients they get, and to see what their bone quality is, whether they have osteopenia or osteoporosis, whatever it may be, to see if they need to be treated.
Right.
Um, but I've been in practice for 20 years.
Hmm.
So at this point, I know what bone feels like, right? So I know touching someone's bone, whether it's appropriate. And yes, you see patients, because it's not just that they're, the obesity is obviously part of it,
Okay.
but obesity leads to decreased activity. Decreased activity leads to weaker bone.
Right.
And there's something called Wolff's Law, which is basically talking about in physics, which talks about, if you bear weight, you're going
Hmm.
to increase your bone mineralization. So
Mm.
people who sit on their butt are going to have weaker bone.
Right.
And people who are obese sit on their butt more than people who aren't obese. So,
Yeah. And we know that weight training, and it is in exercise science, that weight bearing exercise actually helps
mm-hmm.
bone density, increase
Yes,
bone density even
right.
in later years. So it's, even though they didn't do a lot of weight bearing exercises all throughout their life, if you're in your 40s, 50s, and even in your 60s, you can actually either maintain or reduce the degradation over time, right? And also, that's a nutritional thing. So, bone density and muscle density, muscle strength is totally a nutrition game. And we talked about this yesterday. The gold standard across the medical industry, across all health practitioners, is about as simple as this: exercise and nutrition can prevent so many things out there in terms of a lot of conditions that we see. 50% or more of Americans are obese. And with that obesity, it's all these other co-conditions, like asthma or diabetes or heart disease or cholesterol or high blood pressure. These are things that type 2 that can actually be reversed just purely through diet and
Yeah,
exercise.
and the
You
and
know
the
that.
thing the
It's
thing I tell patients too, when they see they get frustrated with things like, I look, we were always limited. It used to be you went running for
right.
exercise years, decades. You went running,
Mhm.
right? Or you didn't, and you lifted heavy weights, or you didn't.
Yeah.
And I educate patients all the time. There are so many different ways to exercise,
Right.
right? From TRX to Classic, to all this other stuff, right? So there's so many things you can do. So they're really, no matter how limited you are, and people have, look, the problem is people have limitations. If you have a shoulder problem, you can't do this. And if you have arthritis in your knees, you can't go for, but there are so many different things to do that will allow you to, as you said, have that nice balance between
Mhm.
exercise, I'm sorry, and diet. And as you know, look at nutrition now, right? There's, compared to 20 years ago, there's so many different options. Was gluten even a word 20 years ago? Of course not. And whether it's dairy free, gluten free, whatever it may be, vegan, all these things, there's so many different options, and which wasn't available. So, not to be harsh, but people have less excuses now to do those things. There's so many options for people to
Yeah.
be able to be more healthy, to avoid surgery, right?
Right. Right. Well, it is emotional for a lot
Of
of
course. Yeah.
people. And sugar and highly refined carbohydrates, it acts like sugar in your brain, and you become addicted. And so it becomes an emotional addiction, it becomes a physiological addiction, And it's hitting up on your dopamine, your pleasure hormone. So
Right.
this is a very addictive cycle that happens, that's so deeply embedded in our nervous system, across our neurotransmitters. And so it's complicated. It's hard for people to undo that. It's not like just a diet is going to fix it. So it really is a journey. It really is possible, but it is a journey in terms of really unpacking all the emotions behind it and the fear behind it, and really understanding the neuroscience behind it as well. So let me
Yes.
ask you one last question, Doc, and then I'll open it up to questions
Sure.
to the group. But
Sure.
what's the general lifespan of a new knee or joint replacement typically?
Well, that's another thing with respect to weight. So someone who's very heavy, as I said, the structure, I mean, everything has a failing point. So if you put an implant in someone who weighs 300 pounds,
Yeah.
that's not lasting 20 years. Someone who's healthy, who the joint has done well, 20 to 25 years is a possible lifespan of that replacement. Someone who's very heavy, it's not lasting that long.
Mhm.
Another thing I will say, since we have an audience, is, my our we were instructed, we were taught, we'll say, when I was in my training, that you want to prolong joint replacement surgery as long as possible, which I agree. You want to push it down the line because you want to operate on someone once. If they have a bad joint, push it down the line as possible. But now the philosophy is, if people have gone through weight loss, life changes, therapy, injections, you can do a joint replacement when they're younger, because people want to be active and be happy in their prime of their life, as opposed to be miserable in the prime of your life and then be deal with these things when they're older. And I think that's why I take everyone differently. I've done joint replacements in people from the ages of 35 to 95, and I think that everyone has a different reason. And I think that's, again, doctors, and for people who go to ever have to be an orthopedic surgeon, just make sure they treat you like you and not like just someone who has your diagnosis.
Right. That totally makes sense. That totally makes sense, because people want to be free in their bodies. They want to travel. They want to walk. They want to go dancing. They want to be walking on the beach. They want to do all the things that they dream of doing, and in their 50s and 60s at retirement. And why shouldn't they? But it's totally possible to make some course correction before taking it to the joint replacement option, where there is a recovery time and there's complications and risks with that. So lastly, just like, how important are the lifestyle factors? I mean, you've been saying this all along, to maintain, well, I guess you've already answered that question. To maintain the success and longevity of the replacement, it's really about maintaining your health, right?
Right. So there are patients who will say, okay, I'm overweight, I need to lose this weight prior to surgery and this and that. They need to continue that. That's not, I've seen patients, and this is the most wonderful thing to see, is patients who work their butt off to get the surgery done. They get it done, and then they use that as a kind of a springboard, and then they just take it and accelerate, right? Because now they have less pain, they can, exercise more, they're more motivated, and that's the greatest thing to see. Patients, it's life-changing, right? So these patients, I saw a patient once who came in, he weighed again, 280 pounds, something like that. And I did his knee replacement, and he, because he had exhausted everything else to that point. And he came in to see me for his other knee years later, and he had lost 150 pounds. So, I mean, it's amazing what these people can do. And I think that, look, it's psychological, it's physical, it's emotional. There's a lot of different factors. And as long as that's taken into account, I think patients can be treated well.
So, and I guess on the opposite side of that, you probably have had patients come back after they have had complications down the line, or they haven't really changed their lifestyle or changed their health around, and maybe you've had to fix things again.
Yeah, which I hate doing.
Yeah.
Which is not fun.
Yeah.
Right.
Right. Okay. So any questions from the group? I'm going to take some questions from the group. If you are in the Zoom room, just raise your hand. Is there a hand to raise? Okay. Let's see. Fred, Fred is also one of my colleagues. He's a personal trainer. So Fred, if you don't mind just introducing yourself, and then my question is, because we have a bunch of questions probably coming up.
Sure. So my name is Fred Hahn. And that was very interesting, Doc. My question is, I had a partial knee replacement on my right knee, and I have, due to bad arthritis and just the medial aspects of my knee, and my left knee is getting there. Even though I'm lean, I eat well, it's just little by little it's deteriorating. So have there been any advancements? I had what was called a Makoplasty, partial knee replacement,
which I
and
do.
I don't want to go through that again.
So advancements with respect to, I did just to give you sort of a frame of reference, I did research in how to prevent osteoarthritis, or to along those lines at Mass General, probably about 30 years ago. So this has been obviously something that's been a long time sort of journey in medicine. And I will say that, because of our population and everything else, and even in not just in joint replacements, but in musculoskeletal medicine, biologic treatments are like the biggest area of research, and to talk about alternatives. But whether it's your own stem cells, whether it's your part of your blood, whether it's fat cells, ironically, we talk about the adipose tissue having these inflammatory, side effects. Fat cells also have a high regenerative capabilities, and I've done cases where we actually take fat cells, spin them, and inject them into arthritic joints, and I've had some success with that. Now the problem is sorry, one second. The problem is the medical literature is quite sparse, so there's not a lot of literature to support this. I don't do a ton of it because it costs money. And patients have to pay money, and I don't feel comfortable charging patients for things that I don't have a good sort of handle on, and no one does. I've been to conferences. This is my biggest area of interest because this is where medicine is going, where we can do something to either reverse, stem, or improve someone's symptoms with respect to arthritis. We'll take someone like you. How great would it be if I could draw your blood, put it through a centrifuge, and then inject it into, the factors into you, and then your pain is gone. Or better yet, your arthritis or your cartilage gets regenerated, right? That's where we're going to be in 30, 40 years. But today, 2021, we don't have that ability yet to say that.
Okay.
But I try those things because if patients, I discuss it, I educate my patients, and I've had these patients with respect to the fat cell issue where they say, look, I don't mind paying the money. If you think it might help, let's just do it. And assuming they fail everything else. And I've had some success with that, with arthritis. And, there's no downside because it's your tissue we're injecting into you. So there's very little downside.
Thanks.
So Doc, is that a treatment that is kind of not covered by most insurance companies?
Yeah, it's not covered. And that's why I work in an area that is a suburb of Manhattan, but not a wealthy area. So patients don't have the financial flexibility to just throw money. And if you look this stuff up on the internet, there's all these clinics that will do these things, and it's very expensive. And I have a problem, as I said, it's difficult to charge patients money for things that don't have a lot of scientific backup.
Mm-hmm. Thank you.
Sure.
Fred, if you don't mind muting yourself, if you don't have any other questions. And then Shelly has a question. So Fred, can you mute yourself? Yeah. Shelly, do you have a question?
Yes, I'm Shelly Kemp, and I have had 3 of your 6 surgeries. And as has my sister. It seems as though we just don't have good, I don't know what. I'm looking at a jaw replacement, and I know that it is said that shoulders are the roughest to recover from.
No.
I found my hip hurt like crazy because I didn't come home with a pain pump and have that for 3 days, and then have heavier medication for the next 4 days. So I had a week out from cutting my leg off. And
I will say this, in my experience, people want to know pain levels. And again, everyone's different, right? So everybody's different. But I would say pain wise, the knees are the worst. And the reason why, and the shoulders are next and the hips are last. And the reason that is because of the soft tissue envelope or the muscles around, right? So you have no real muscle around your knee joint itself. It's skin and then there's bone. So there's a lot of pain and stiffness. Now, your shoulders aren't usually as much of an issue only because you don't walk on your arms. So people are much more disabled by things in their lower extremities or their legs than they are in their arms because, if you can't walk, you're much more incapacitated than if you can't lift over your head. So, but again, I say that, but that's not an absolute. People are all people have different. Your response is different, and for all we know, you say, well, I had 3 joints replaced, but your hip may have been a heck of a lot worse than some. So meaning that your surgery on your hip may have been a lot more complicated or more difficult or required more soft tissue stress and insult, right? Because surgery is controlled trauma. So, right. So that's certainly a reason why a hip would hurt more than another joint. And it really has to do, and again, as I said before, everyone's different. So everyone's going to have a different response to medicine, therapy, surgery, and so, look.
And you don't believe that when they made the don't give narcotics anymore, when they came down and said from now on, narcotics are bad, give them less than narcotic.
Well,
You don't trust people to take them for the 10 days that they're going.
No, I think, I'll be honest. No, I give patients narcotics after surgery, but I will tell you something. My partner, who sits 2 seats down from me in my office, and we have very similar patient populations, okay? And we do similar surgeries. Pain is real, but perception of pain is emotional, psychological as well. It's all about how things are presented and understanding and fear, right? So people are very scared of pain, rightfully so. Pain hurts. No one wants to be in pain. And I think I spend a lot of time giving people their expectations of what's going to happen after an operation. And I think once that fear is minimized as much as I can do, they just need less pain meds. And I've seen that. And that's something, the whole anti-narcotics wave that's happened in this country, which I think is important, but narcotics are needed sometimes. But the way that I explain to patients about narcotics and how they use them has caused, I hardly write any narcotics. And it's not because I don't believe it, it's because my patients don't ask for them. So I think there's a lot of that education and information, the disseminating of information that needs to happen to people. And I used to think, like, I was nervous that if I stopped, patients were going to freak out and I was going to get all these phone calls. I even started giving my cell phone number to patients because I wanted to see, if someone really needed it, they're going to call me at 3 a.m. that they're miserable. I received almost no phone calls. And this has been for a number of years now. And again, that's because although pain is real, there's perception of pain, how people deal with it. And I've just seen that it's gone very well. And I think we can all agree taking narcotics, too much narcotics leads to poor results. I actually won't do a joint replacement on someone who's on narcotics because that's been shown in multiple studies to have poor results. Because if you're on narcotics ahead of time and then you have an insult, traumatic experience, which is surgery, now how are you going to control that pain? If you can't control the pain, they won't walk, won't move their joint, and they have poor results. They get stiffer. They have more problems. So I try very hard to incorporate that into my education with the patients.
Yeah. So thank you, Doc. Shelley, did that answer your question? You had really great questions there.
Yes.
Okay, great. Thank you. We're going to go to Teresa next. Shelley, if you don't mind just muting yourself. Thank you.
Hey, doctor, this is Teresa, and
Hi.
I want to thank you. This was an amazing topic tonight. very passionate for me because I am a RN. I worked for actually 5 orthopedic surgeons in my early days. I've since been retired. And I just took recently a webinar course with Tina. And I've always tried to embrace nutrition and physical fitness. I actually went on to become a personal trainer. But what I'm really curious, because I now know with today's bad eating habits and the obesity issues that are going on, I'd love to know, since you mentioned earlier that you will sometimes see younger people for surgeries, like, I don't know if it's knee replacement or hip replacement, but what percentage of your patients are under 50 that you do surgery with, as opposed to the percentage over 50? Because I'm seeing more and more obese under 50 than I've ever in my lifetime. And I mean, all you have to do is go to a mall and look around and see what people are eating in their hands, and the age group. And I'm just
Can I
shocked.
ask where you're located?
Right now I live in Newport Beach, California,
All right,
but
so that's actually not so. When you look at this map I referenced, I mean, really, I'm in the New York area. I have less obesity here necessarily than there are other areas, although I think our country has a lot of obesity compared to other countries. So to answer your question, I see. Well, I try very hard. There's more obesity. See how I can answer this. There's more obesity, I think, in patients who see me for arthritis over the age of 50. But I see more now under the age of 50 than I used to. So I think that I try very hard not to operate on these patients. I mean, I really try, and I almost, there are patients that I have just said, look, even if they've exhausted conservative treatment, I just won't do it because I know they're not going to do well, and I know they're going to have these problems. And I hate saying no to people, but every patient's different. You have your patients, like I just explained before. This patient weighed close to 1,000 pounds, and she's done as much work as I've ever heard anyone doing. I've never heard anyone losing that much weight. I just haven't in my practice. So I almost want to reward her because she's done so much work, and she needs it, and she's going to be happier, and she's under 50.
Yeah.
But she's more of a unicorn. So we don't see that really. We see patients who they just, I have one patient. She always comes to my mind. She's 5 foot, 5 feet tall. She weighs like 260. She's like a ball. And I keep talking about weight loss. She comes in once a month for both knees. She needs knee replacements, but as far as her x-rays show. But I told her, I go, look, you got to lose weight. You got to show me. You have to show me. The surgery is not this sort of cure-all and this sort of magic key that's going to turn and fix your life. There has to be a whole lifestyle change. And for Tina, like for people who deal with nutrition and health and non-surgical health, it's important that starts before, because trust me, they're not going to do it after. They're not. They might, but they need to get on that road before, and they need to understand how their life has to change for the surgery to work, and for them to take that and go as they're done to get on with their life. But I really, patients who don't try, I won't operate on.
Yeah. Thank you so much, Doc. Thanks, Teresa. Was that?
Yeah, I just wanted to thank the doctor and you, Tina.
Sure.
This is very informative, and I am really looking forward to tomorrow night's.
Yeah. So Teresa and I are going to be speaking tomorrow night about collagen and hyaluronic acid. So basically, as a supplementation for anti-aging, feeling good, for weight loss, for all of these things. But we're going to talk about really targeted nutrition. We're going to talk about general nutrition in terms of really eliminating bad foods or foods that aren't serving bone health or muscle health, but also talking about targeted nutrition, things that you can supplement with. But a supplement will never, ever, ever replace changing your diet for the better to actually help you have strong bone density, have strong muscle mass into your 50s and 60s. So we're excited to tomorrow night. We're gonna be at 7 o'clock. I'm gonna be on with Teresa, and she's gonna share with us all of her knowledge around those two collagen and hyaluronic acid supplements. So Before we get to that, I think there was another question from Lisa. Lisa, did you want to just turn your mic on if you can't do camera? Did you have a question about your husband?
Yeah, and he left the room, but he's the one that asked it. Basically, he has constant chronic neck pain.
Okay.
He's in good health otherwise. He exercises regularly, eats well, runs. He's very active. But at one point in his life, when the neck pain was getting really bad, he went to a sports doctor who actually said he had a syrinx and that he recommended he see a neurosurgeon immediately. So he did go, but the neurosurgeon said that it was a very old and small syrinx. And if it hadn't bothered him, his recommendation was just to continue what he's doing. So lo and behold, here he is. It's still chronic pain that he gets in his neck. I would say that I hear him talk about his neck at least once or twice a day about the pain, and he doesn't take any kind of pain pills other than like Motrin or some other thing to get him by. But what are your thoughts on that?
Well, I mean, it's hard for me to tell you. I mean, look, I assume he had an MRI that showed the syrinx, because you can't diagnose that otherwise. So, we find these things. I don't even like to get tests unless I'm going to act on them. And the problem is, with more tests, you find more things, and then with more things, and you're like, what do we do? So what has he done other than see the doctors? Has he done anything for his neck pain?
He's seen a chiropractor occasionally, but it's just
okay. So I will speak from someone who I had neck surgery from a diving accident 36 years ago myself. So I have chronic pain in my neck as well. So I can appreciate the pain, because sleeping's hard. Daily life is hard because your neck is in one position. It's a very difficult thing. Any spine problems and any of these issues are hard to deal with. So it depends on why he's having pain. So it's not the syrinx, most likely. Obviously, without seeing him or his MRI, it's hard for me to say, but it sounds like it's not his syrinx, which was probably an incidental finding. So it's most likely a degenerative process versus a muscular issue and a flexibility issue. And although, there are certain things that we can do and things like that, sounds like he needs to be treated. And the way to be treated typically is physical therapy. I have no problem with chiropractors, depending on the chiropractor. I think that some chiropractors are good and some are terrible, but there are some orthopedic surgeons that are good and some are terrible. So I think that there are different ways, but getting in a regimen and gaining flexibility, gaining strength, the cervical musculature is postural, so it's constantly firing. So if those muscles are not in shape, you're going to have pain and problems with that. Postural thing, the way he stays, many different things. So I'll just give you a little personal. For me, because of my neck, and I had exhausted a lot of different things, I actually started doing yoga. I took 2 years. I did private lessons it's expensive. So, for like 3 days a week, I was doing private lessons, and it made a big difference for me. Not saying that he needs to do yoga, but there are a lot of things that are going to increase flexibility, increase strength. And I think he needs to going to a chiropractor every once in a while is okay, but he's not really treating it.
Right.
It's activity modification, hands-on treatment, taking supplements. He may have arthritis in his spine. The spine has lots of little joints in it. You can get arthritis in that as well.
Okay, good. Thank you.
It's getting really, we're a little bit later than 7:45, 5 minutes past. If there's no other questions, I just want to thank, Lisa, can you mute yourself? Do you mind?
Yes.
Mute yourself. So I just want to thank Dr. Fond, Dr. Jason. You are so amazing. And I love the fact that you were able to really kind of share from such a holistic point of view in terms of prevention and giving everybody a little bit more insight around, what it means in terms of, hold on a second. Sorry. I don't know why I'm why this is happening, but what it means in terms of really being able to prevent obesity, work on things in terms of being able to make that daily effort to get your life back, to get your health back before other complications start. So, our time is precious on this earth. Our time in our 50s and 60s is a time when we want to really enjoy life, right? So we want to be able to go on those healthy walks and be able to enjoy our families and be able to experience things. So I'm so grateful for you, Dr.
Well,
Jason.
thank you very
Thank
much.
you so
And I
much
think
for
that
the insights.
I appreciate it, and I'll talk forever. So
No, that was
I
perfect.
keep going.
That was so perfect. And if you guys have any other questions, hey Doc, how can people find you or learn more about you? Or are you going to be doing any talks?
Okay. Well, it's funny. I did a talk about shoulder arthritis on a YouTube. But if you want to, I can give you my the website of my practice, and you can reach me through there, and you can find out any information. And look, I'm happy to answer any question you have. If someone emails me something, I'll do the best I can. I mean, it's hard sometimes if I can't examine you or talk, but general questions, I'm always happy to answer. But the website is www. It's NEOSM, which is Northeast Orthopedics and Sports Medicine. So it's NEOSM team.com.
Oh, awesome. Thank you so much, Dr. Jason. I know you are so busy. We're so grateful for your time. And we just wish you the best during the season.
No, thank you guys very much.
Health and safety with
You
your
too.
patients.
Yes.
Yeah, and much success. And thank you for all of your efforts in healing this world and the work that you do. So thank you so much.
Thank you, everyone.
Thank
Have a
you.
good night.
Thank you, everyone. And we will end the call, and I'll see you tomorrow night. Don't forget to sign back in tomorrow night with Teresa. Bye.